I'm Hemal Kanzaria, affiliated faculty member of the Philip R. Lee Institute for Health Policy Studies, an associate professor of emergency medicine at UCSF, and the medical director of care coordination at the General. As a frontline ED doc, of course, I care for patients with heart attacks and strokes and gunshot wounds, but even more commonly, I care for patients with lower acuity medical conditions complicated by underlying social needs. Patients with poorly controlled diabetes, unable to afford insulin, or a frequent ED visitor for asthma due to poor quality housing. In other words, for many patients, health is primarily driven by their underlying social, environmental, and economic circumstances. Thus, I've been thinking a lot about how acute care systems can better meet patients' medical and social needs together. Treatment of medical conditions without considering underlying social needs is unlikely to be as effective, will probably be more costly, and may also lead to moral distress for both clinicians and patients. So a lot of my operations and research work is focused at the interface between individual and community level social determinants of health and the acute care system, including designing, implementing, and evaluating efforts to better meet patients' medical and social needs in parallel. For example, during the COVID-19 pandemic, we've been recommending patients self-isolate and physically distance if they have COVID. However, for someone experiencing homelessness or for individuals living in crowded conditions, that recommendation may not be possible. I've been fortunate to partner with many across San Francisco to support such individuals having access to hotel rooms for safe isolation and quarantine after an ED visit or an urgent care visit or hospitalization while patients are still infectious with COVID. A lot of effort went into developing patient-centered models of care, including harm reduction efforts in the hotels to optimize medical and social care in that setting and preserve hospital capacity for the patients with the most severe medical illness. Similarly, I co-direct the ZSFG social medicine team, where the focus is on supporting patients in their medical and non-medical needs at the point of care by leveraging partnerships with community-based agencies like the Human Services Agency and the Department of Homelessness and Supportive Housing. The concept of medical and social care integration is timely in that it's the cornerstone of efforts in both the anticipated mental health San Francisco reform efforts and the state's CalAIM initiative. Through such initiatives, we have a great opportunity for acute care systems to develop stronger partnerships and integration with community and medical social services, and to identify proactive ways to support our patients' overall health.